All right, well, we're well into the hour here, so I thought we should get started. For those who have not met me, I'm Don Jurovich from University of North Dakota. And if you are new to the program, thanks for joining us. We do encourage additional participation from all the long-term care facilities to engage, you know, other than leadership and quality improvement folks, but also to include people who are just new to the quality improvement game here, and we encourage that moving forward. Uh, Thank you for this slide here. Welcome to the new nursing homes that are joining phase two. Just as an explanation for those that go, what the heck is phase two? Phase two is just part of the AHRQ process, if you will, when they devised this series of presentations. Historically, I think we all know that the government basically contracted with the Institute for Healthcare Improvement to create curriculum that will help guide nursing homes through the pandemic and more generally towards quality improvement, infection control, and engagement. And I think what we all realized is that as we've marched through the pandemic, that some of the biggest issues that are really dealing with us, that we're dealing with, are more behavioral, mental health, and engagement issues that are really affecting all elements of life in long-term care, both in terms for the staff, as well as for the residents, as well as for family members and caregivers, as well as you might imagine some of the community direct care workers who then take some of the nursing home residents who get transferred back to home or to other settings, right? So there's this just huge sphere of folks that are engaged in this and have different issues, related to risk mitigation for COVID. And I got to tell you, there's just like this. I'm getting the impression that there's like people just don't want to think COVID's around anymore. And the reason I'm saying that is that I went to our graduation dinner at a restaurant in Fargo yesterday, and I was the only person that walked into the restaurant with a mask on. And so I figured, oh dear, I guess everybody thinks that we're out of the clear there. Fortunately, I didn't get any odd looks or anything like that. But as a matter of course, our University of North Dakota policy is that if we do have any graduation events, that they have to be outdoors. And it really gets a little more crazy because they asked us to sign these waivers of, that if you get COVID, you hold the university, libel free or whatever. And I'm going like, good gracious, you got to sign a letter just to have a little piece of fish for a graduating party. So anyways, welcome to the group. In terms of today, we're going to talk a little bit about the COVID update, some of the interesting and good data. Looking forward, I think our efforts are really working here. Then we're going to head into the Institute for Healthcare Improvement curriculum. And I'd like to just mention on the side here that if you have not had an opportunity to go to the IHI website, ihi.org, particularly to review their quality improvement resources, please do so. It's really well done. The Institute for Healthcare Improvement is just amazing what they've done over the years, and that they're really a tremendous resource, including what we're calling their program age friendly. And as we move along in this program and with upcoming programs, you're going to hear a lot more about implementing age-friendly healthcare in the context of dealing with older adults and how that's beneficial to them for better outcomes. But anyways, just as that aside, we're going to talk about the IHI presentation. It's a little longer video today. And then what we want to do is we want to launch for the month of June. So remember, well, at least for this new group of nursing homes that are joining us, we have a PIP du jour of the month. So, if you, du jour, I guess, means, soup of the day. And so we have a PIP of the month. Last month, we were focused on social isolation and interventions that are needed or appropriate for reducing social isolation and long-term care. And then this month, we're going to try to zone in or hone in on fall prevention. So, and we'll talk about all the data on falls in long-term care. I don't think anybody's surprised to know that on average, 2.6 falls per long-term care resident per year. In fact, I did a research project here recently in Fargo with the cooperation of Rosewood and Villa Maria, and we greatly thank them because they're not only cooperating with our research programs, but also are one of our peer mentors for this program, because they really are performing at a very high level for quality improvement. And I just wanted to mention that the research that we were doing was on falls, and we're trying to correlate falls with blood pressure changes over time. And what we discovered is that the people that had the most radical changes in their blood pressure tended to fall the most. So that was one observation. But the other observation is that we found absolutely nobody that had not had a fall. So we couldn't compare. There was no control group. There was like no fallers in the facility. Everybody had a fall. So that was kind of a real eye opener for me. So anyways, why don't we move on here to the questions here. So again, we know some people don't have microphones they're in a group. So we're looking for any comments about walk rounds from the last week or so. So if you just want to put in the chat box, if there was any new issue that came up, whether it be, COVID outbreak or anything of that sort, from your walk rounds, just type that into the box there and share with us, please. I guess the other question is, did you do walk rounds? So if you did do walk rounds, just put yes in the box. I guess by default, we'll assume that if you don't respond, that it means that walk rounds were not part of the agenda this past week. So for the new facilities that are joining us today, I just wanted to mention that we talked about structured walk rounds. Again, that they are, so you come in with a list and you have it structured with, questions. You can change the questions from week to week, if you do it daily, from day to day and so forth. Yeah, great. Thank you, Billy. That's great. Doing walk rounds and you're talking about the issues with the unvaccinated staff. That's good. Yeah, so some people are refusing to wear the eye protection. Yeah, I know that's a requirement, and I got to share with you, I'm not a big fan of the eye protection because I'm not sure that that's 100% evidence-based. The idea is that you're trying to protect the eyes, and we actually had this discussion early on in phase 1 about the whole relevance of the face masks, and I commented that while the masks are beneficial, the face masks themselves cause Venturi effects where, as you breathe in, you're actually breathing in and causing a vortex towards the face. And the other part is that when you're talking with people, when you put the face mask on, the airflow goes back behind your head. So you don't really want people standing behind each other when you're in a discussion. So if you're like in a huddle, you don't want people standing behind each other. You want to be sort of in a, circle where, the back of the heads are allowing the air to vent backwards. So yeah, I think these issues are something that we should talk about particularly about the eye protection. And I think this is something that, we should route to our, it's one of the questions that I'd like to route to our collaborative nationwide to see what the national experts are saying about this issue. So Billy, thanks for bringing that up. These are some of the things that we can then sort of send off to this national collaboration and say, has anybody else got this issue? What's your recommendations on that? Yeah, so somebody did staff education during the rounds. That's good. Yeah, interesting about the extremes of feelings. Yeah, I agree. There is a wide range. And then from Jennifer, doing neuro checks after on Witness Falls and not being fully followed. Good. Yeah. So the implementation issue is an important, what I want to say, consistency. I share that with you. This is always, when you do something new, you always have to identify it. I got caught in the act, by the way, yesterday in clinic. I walked out the clinic and the head nurse was standing right in front of the door. And she says, "Did you alcohol spritz your hands?" And I go, "Guilty." And I put my head out as I at the side of the door and got an alcohol spritz there. And I said, "How's this?" And it worked out pretty good. However, the hand washing machine, the towel dispenser was not dispensing towels. So that was kind of our quick huddle for the day, in the midst of clinic. So, and actually it was interesting because, she was doing live time, real time measurements of hand hygiene. So I got a pretty good score on doing hand hygiene in the beginning, but not at the end, I guess. All right, so thank you for that feedback from everybody. And in terms of our updates, what we've learned from Vanessa from the Long-Term Care Association here in North Dakota is that we've got, we have, as of this month, achieved 93% nursing home resident vaccination and 65% nursing home staff vaccination. So that's pretty good. We wanted 70% or more has been the overall national target, but in long-term care and in hospital settings, we would like to see it pretty close to 100%. Since I was telling stories earlier about my college reunion, I was really delighted to hear that 98% of all the alumni that were surveyed, as part of our reunion, had received the vaccine, the COVID vaccine. So there's really a high uptake in my classmates. I don't know, whether that's true in general for college educated folks or not, but that's an important kind of socioeconomic, consideration to think about as to what people understand, in terms of vaccine hesitancy. And again, there's no proof that the vaccines have any impact on fertility. Same thing with pregnancy, no impacts. And so I think this is just really exceptional news for an exceptional vaccine. Good. Okay, so we can move on to the next slide here. So congratulations for everybody who's gotten folks vaccinated in their facilities. I just wanted to share this with you. This shows the health, the mortality rate that COVID has taken on minority populations, so Black and Latinos. You can see with virtually every age group that there's a huge gap in terms of the ratio of the number of deaths for individuals. And a lot of this, again, may have to do with resources and socioeconomic status as opposed to race or ethnicity per se. But again, we just need to be reminded that we have groups that we need to be attentive to who are at higher risk than the general Caucasian population. So that's true for both staff and for residents. So again, just a reminder that there is this discrepancy that we need to be mindful of. Next slide, please. And I think we're heading into the video. So I'm going to mute myself and take a listen to the video here.
Hi there, my name is Paige Hector, and along with Angela Devaney, I am excited to bring this module, Emotional and Organization Support, to you as part of the continuation phase of Project ECHO. In this session, Angela and I will cover these objectives. We'll be talking about nonviolent communication with an emphasis on two components, specifically feelings and needs. How attuned listening, what is it, and how it relates to the basic need of being heard. I'll talk about a couple of tools that you can use to help increase awareness of your emotional state. And then Angela will talk about direct observations and process maps and how huddles can be used by all staff. This particular week is the third in a series of 5, and we do, as we've said before, recommend that you go through these weeks in order. Before we dive into the content for today, what's new? What's come up for you in the past week? Are there any questions or issues that you might be struggling with? A reminder to reach out to your training centers and the staff here, because we are all here to help you and are eager to learn right along with you. In order to make our time together today as interactive as possible, we'll start off with a discussion question based on the weekly topic. So for this week, what is a feeling that you've experienced lately related to the pandemic? Okay, let's jump right into it here. I'm thrilled to be bringing this topic to you, nonviolent communication. It's something I've been doing a lot of work around, a lot of studying and taking a lot of classes, and I do believe that this is going to be something really exciting to bring to our world of nursing homes. I've been doing some writing about it, and basically, nonviolent communication, it's a set of skills. It's a communication model that we can use each and every single day with or without conflict. For me personally, I notice I'm using it work-related situations with my son, my husband, my friends, and family. So it's something that we can use day in and day out. I want to make it clear that it's not a formula. Sometimes you might hear it called compassionate communication. But basically, it's a skill that allows us to bring presence into all of our interactions and gives us an expanded capacity to hear and express ourselves, to hear others and express ourselves. It is something that we can actually do. And if you remember from previous weeks, we talked about one of the biggest challenges with the pandemic is the feeling of unpredictability and immobility. Nonviolent communication is something that we can actually do starting right away. So NVC has 4 components: observations, feelings, needs, and requests. We don't have time to go through all 4 of these, so we're going to focus right in the middle. We're going to talk about feelings and needs and how those 2 are correlated. So at this moment, just think about a moment how you feel in this minute. How are you feeling? Is it scared, confident, irritable, relieved, exhausted? There are so many different words. You don't even have to include the word feeling. You don't have to say, I'm feeling confident, I'm feeling irritable. You could just say, I'm feeling. So in this moment, really pause right here and ask yourself, what are my feelings at this very moment? So to build on the last week, where do the feelings show up for you? So if you were to say, I feel exhausted, I'm going to ask you, well, where does that feeling show up for you in your body? Is it in your mind? Is it in your muscles? Where do you feel exhausted? At the same time, maybe what if you feel delighted? Like, where does that show up for you inside? Like a little burst of energy somewhere? Do you feel a lightness? What is it? And try to describe it. Our feelings are super important because they are ways that tell us, they inform us that something is not okay, or it could actually be okay. But most often, when we have feelings around things that are not going well, that are out of balance in our lives, our feelings tell us that something requires attention, and it points us in the direction of what we need, and so they really do keep us informed. Feelings can also tell us when things are going well. I'd like to encourage people to think about when you feel ecstatic or content or satisfied or any number of feelings. Really take stock and notice, how does that show up for you? What is the experience of feeling those particular states? And that's kind of what we want to be going toward. This is one of my favorite, handouts, you could call it. I have this laminated. It's on my desk. I have actually 2 copies in case I lose one. This is from nonviolent communication trainer and expert Marianne Van Dyke. It's from her website, Cup of Empathy. It's a free download. If you look here on the left, feelings when my needs are fulfilled, you're going to see 3 columns with the green little lines at the top. Just look at the variety. You know, if you say cheerful, it could be happy, amused, joyful, cheerful, delighted, ecstatic. There's so many more words in our vocabulary that we may not even tap into yet. Feelings when my needs are not fulfilled. So look at the right-hand side of those columns with the yellow or orange line at the top. So if you're feeling tired, look in the middle there in the second column, defeated or burnt out, exhausted, sleepy, weary. Just take a look at this. If I were to ask you at this moment now, based on these boxes here, which ones might you select? So if you remember last week, we talked about increasing our emotional intelligence. This is part of that. It's expanding our emotional vocabulary. I want to take a quick side trip for just a moment. I want to talk about an emotion that I call it very sensitive or even tender. I've heard a lot of people in healthcare say that they feel guilty. They feel guilty for what has happened with their patients. This is a really sensitive emotion. And if you look up the word guilt, the definition is that responsible for a specified wrongdoing, and synonyms include blameworthy or at fault. The feelings of guilt usually come with a lot of baggage, and we're conditioned to use this word, but I'm concerned it may actually be adding to our distress. So do you ever say, well, I feel guilty. I feel guilty I'm not doing more. I feel guilty I can't fix this. I feel guilty that she died. I feel guilty. What if I were to invite you to reframe that emotion as an expression of sadness or helplessness? Let's try and substitute. So instead of I feel guilty, I feel sad. I can't take away the pain. I feel helpless in this moment. It kind of takes away that feeling of pressure, like we individually are at blame for something for which we are not. I truly trust with all of my heart that all of us are doing the best we can and showing up with the most present we can at every given moment. There is nothing to feel guilty about. Once you've identified your feelings, and I, again, encourage you, there's lots of nonviolent communication free resources and tools out there. Print off any number that you like. Use them to look at the words, which ones resonate with you to help you expand your emotional vocabulary. Once you've identified the feeling, now we're going to pair it up with a need. For example, well, I'm feeling irritable. I need time alone and a snack. I'm scared. I need more information. I'm relaxed, and I really appreciate that my supervisor listened to my idea. The listening is the actual need to be heard. Well, I'm feeling overwhelmed, and it's important to me that I can ask for help when I need it. So for that example, the need in there is trust. Trust that when I ask for help, I'll receive it. So you can see here how needs can be met or unmet. They're both super important to figure out. So this is the back half of that Cup of Empathy worksheet. So once again, I just invite you at this moment to pause and really take stock and read some of these words. I'll tell you where I keep landing a lot in my work lately is a lot about connection. For those of you familiar with Brene Brown, she talks a lot about human connection and how important that need is, especially during these times of a pandemic. So look at the connection box in the middle there. You'll notice that there's to give and to receive, to see and to be seen, to hear and to be heard and understood. Those are critically important needs that we all have, no matter our race, our ethnicity, our gender, our age, our culture. It does not matter. All of these are basic human needs, and they all belong to all of us. Now, just a quick word of caution. I'm bringing up topics that we may not have talked about in nursing homes or in healthcare in general before, or at least to this degree. And I just want to point out that, you know, all of us want to be heard and understood for what we have to say. Think about it for a moment. Every time we speak, It's because we wish to be heard. We have something to share, to give, to offer, and we want to be heard. That's a basic human need. And at the same time, just because I offer that, it may not mean that I'm ready to kind of delve deeper and look deeper at what the feelings and needs are. So my word of caution, everyone, is as we bring this expanded language and we talk and do things differently, and we bring this world of trauma-informed care, of which this is certainly a part of it, as we build safe and trusting and work cultures, we need to appreciate that some people may not be quite ready for that, and that's really okay. There's something I call it respecting the no. That, you know, we can invite people to this world and to this work, but some people may not feel comfortable, and that's okay. There will be many people who will be excited to talk about this and bringing expanded awareness of our emotional intelligence on board. Being heard is a core human need, and I pointed that out to you on that worksheet a couple of slides ago. So the correlation here is that when we listen to one another, when we truly listen, after we truly feel that we have been heard, we are in a better position to listen. It doesn't mean that we have to agree with each other or be on the same page at all times. What really it does mean is that we feel heard without judgment, without blame, and without criticism, that your point of view is heard, that your point of view is understood. And when you feel that, you are more willing and able to listen in reciprocity-wise. So attuned listening, you may think of it as active listening. I view it a little differently. Some people might call it empathy. Dr. Marshall Rosenberg, who is the founder of Nonviolent Communication, he would use the word empathy. So I'm going to use these a little interchangeably. Basically, here it is. When we are present with someone, I used to have a saying when I worked in the world of palliative medicine more, is the essence is presence. That when we are present with someone, that we're sending the message verbally and non-verbally, I am here, I care, I have the spaciousness, and I am available to be attuned to you, to express empathy and to be present with you, even with your grief. When we can do this and we come prepared with no agenda, truly, we come prepared with no agenda, how's that? There's no need to fix or solve anything. That when you truly listen to someone, when you give your full attention to that other person and you're meeting their basic need to be heard and understood, building trust, building safety within your culture. When they shared something with you, you pause, you recap what they say, and then you can say something like, did I get that all right? I want to make sure that I understood what you have to say. I'd like to repeat it. How did I do? If you missed a part of their message, that's okay. That's totally fine. Just ask them to repeat it. If yes, what I love to do then is there more that you'd like to share? Especially as people come to trust talking and using this different language, literally a language of communication, they might be a little unsure at first. Invite them and say, is there more you'd like to share with me? I'm still available to listen. Simply to listen. Some of our speaking habits that we have, all of us have used some of these, maybe all of us have used all of these at some point. When our speaking skills devolve, some of the things we resort to out of habit, think about how uncomfortable we can be, especially if someone is in a state of stress or distress. Our inclination is to fix it, to take the stress away, to make it right again. What if we didn't do that anymore? What if we didn't do that? If we stepped away when someone is expressing to us how they are feeling and what they're needing, no more advice giving, no more blanket reassurance, oh, it's all going to be fine, don't worry so much. Or have you been in an experience where you start telling someone a story and then they turn right around and tell you a story about their experience and you're like, wait a minute, I was talking here and I don't feel heard yet. You feel incomplete. Telling the other person, well, look on the bright side of things. Well, at least you don't have, or at least you didn't. Maybe we interrogate the other person. We pepper them with question after question, and it's exhausting. Do we change the subject? Or do we engage in a little bit of blaming, like, well, if you hadn't have done this, this wouldn't have happened, kind of that blaming flavor. We disagree or we agree with them, or we do the, I hear you, but what, and then we do the buts, right? All of these are ways that disconnect us with another person. So at a time when we need more connection to come together, to have an expanded language, to talk with each other and to hear each other, if we can move away from these things, our emotional intelligence will go up, our ability to be present will go up. So here's a great place to stop and have some discussion. So think of a recent experience in which you were sharing something, an experience, your thoughts, your feelings, just something. What did the other person do or say things that impacted your perception of being heard or not heard? So just pause there for a moment. Think about what those were. Did they say something? Was there body language involved? What did it look like, sound like? What did it feel like? Let's say you finished speaking. How did you feel when you were done? Did you actually feel heard and understood? Did you actually finish speaking, or did you disconnect either yourself, or did you feel disconnected by the other person? And did you feel completely heard? Why or why not? So the more that we pay attention to these needs, we will be better able to identify when our needs are met or unmet, because we're learning to pay attention. We're bringing more awareness on board. So what do we do with all this awareness, right? Here it is. Here's one idea. This is called the check-in board, and this was modified from the Stress First Aid Kit. This is a wonderful visual, and the way that I've been talking about this with different groups is you could actually create like a whiteboard or some kind of visual display on each of your neighborhoods or units, whatever language you use in your nursing home. And it's a way for staff to share. The green, you can look at the green arrow. So I feel good today. I'm able to help. Okay. So there's some distress. I may need some support today in the yellow zone. The orange zone is, it's a little bit more concerning. I'm struggling today. I might need some alone time. Red, help. I need help. I need support. Normal everyday interactions, we typically vacillate green and yellow, right? That's just normal human experience. We've all delved into the orange at some point in time. Again, normal, but it's when that's persistent or when we begin stepping more into the red zone that's really concerning. So the goal here is to connection. It's for connection, to create the environment that people have permission to speak their truth, to talk about if they're in a state of struggle or distress. And then we have to ask ourselves, does your culture really support people sharing, giving permission to share their truth? And then I want to make sure that we consider, how do we include everyone in the nursing home, not just clinical staff or department heads, but how do we include operational staff, everybody that works there? So the other thing too is that if you choose to engage in these types of strategies, we then have to do, well, what then? So if we have staff who are in the orange or red zones, this could be a process improvement project. Like, what would be the resources available to your nursing home? What could you do in that moment? What do you have available? Because at any point in time, any of us can be, we're all in one of these, right? But if we have people that are consistently showing up in orange and red, those are people in struggle and we need to help them. Okay, again, we're not becoming therapists or each other's therapists, but we need to have some sort of process in place to recognize and address the distress. The leaders on this call, I see you as role models. Wouldn't it be wonderful if you could begin a meeting or a staff meeting or talking one-on-one? Hey, I'm focusing on my emotional well-being and I'd like to support yours as well. Let me show you this tool. Right now I'm over here in the yellow zone or the green zone. So again, I'm giving you a language to talk about, to notice what's happening, what you're feeling, what your needs are, and where you are on this continuum. Another strategy here is the temperature with a thermometer. So what's your temperature? So we've been taking our temperature a lot with COVID, of course, but this is a little bit different. This is your emotional temperature. You could incorporate this throughout the day, the shift, the night shift, whatever it is that makes sense for your particular culture. And then you can look at the different categories here. So the green again is, you know, I'm feeling great, I'm relaxed, I'm happy, cool, and collected. But then as you go up the thermometer, I'm heating up, or I'm boiling, I'm ready to explode, or I'm exploding out of control. So the idea is to catch these stress responses. Remember the feelings, and then what clues the feelings are giving us about our unmet needs? And then how do we support our staff to transition and kind of hopefully keep us more in that lower blue and green zone? Remember too that feelings are temporary. When we feel distressed or in struggle, eventually that too is going to pass. And sometimes we just need to be reminded not to pass over or give advice or do any of those things that I just talked about a few slides ago. But if we have a staff member who is more centered and more balanced in that moment, maybe we have a system in our nursing homes where we can reach out in the buddy systems or whatever it is to help our colleagues to get through a particularly difficult moment or a difficult day. So the connection to self-care is that when you feel triggered, invite breath. The more, and I'll talk more about breath work coming up a little bit later in another session. Slow down. Remember your yellow lights, your stress responses. Identify what it is you're feeling in the moment. What is it you need? It's the practice of intentionality. We're bringing more awareness around this. Just like if you wanted to increase muscle mass or your strength, you would be doing physical repetitions. It's the same thing with our emotional well-being. So thank you for sharing your time with me. Next week, we get to discuss the basic human need of mourning and why this is so important. Thank you.
Very good. So some very sage comments. And we want to, I put in some comments to Billy's question about the face shields. And there's a lot of controversy about those, but the bottom line is that when something is aerosolized, it can go into the conjunctiva, as well as into the nares and into the oral pharynx. And so the idea is to try to, reduce that. There was also a study of in China that found that people who wore eyeglasses in the community more than 8 hours a day had less hospitalizations for COVID than people who did not wear eyeglasses. And so there were some implications there that somehow the eyeglasses maybe deflected COVID, but that was in the community setting as opposed to a healthcare setting. All right, so we want to talk a little bit about the falls, and I just want to go through some data here just to set the stage. We know that the fall death rates in the United States, as done by surveys, have increased both in the community, community, as well as in long-term care, as well as in the hospitals. So for whatever reason, the baby boomers seem to be the granddaddies of all fallers. Don't know why that is, but this is the data. Next slide, please. So just some facts here, like four squares here, like tic-tac-toe. Each year, we know that nursing home residents have over half falls. Like I say, it's 2.6 falls per resident per year. And a lot of times these falls are not reported. And we know that more falls from nursing homes result in serious injury than in the community. So generally we think of falls in the community as being like 1% serious injury, not so much in the nursing home. And the reason for that is that the nursing home resident generally, is vitamin D deficient, they're sedentary, their bones become more brittle. And so for every fall or even spontaneous fracture, there's one study, by the way, folks, that shows that 20% of broken bones in nursing homes are due to non-trauma. They're spontaneous. And there was a study that came out of Texas, and I've done, half dozen or so medical legal cases where the plaintiff lawyers are saying, well, it was the nursing home fault that they broke their leg. And I said, they found them in bed with a broken leg, so it must have been the nursing home's fault. And I said, no, they could have just twisted themselves in the wrong direction and had a spiral fracture, which is in fact what had occurred spontaneously. And so a lot of folks are undereducated about the fact of spontaneous fractures. I mean, we all know this to be true for osteoporosis, where just a very vigorous sneeze can cause a vertebral collapse. So so too in the long-term care setting where the bones become more fragile. And the other thing that I found interesting in terms of the CDC statistics is that 1/3 of nursing home residents who fall are not able to transfer or walk on their own. So again, that whole transition from bed to ground or wheelchair to ground is an important issue to consider. Next slide, please. Yeah, so just, the death rate is quite high in the nursing home setting. And that's true for all 65 and older in particular, as well as for younger patients or residents. Next slide, please. So just want to cover just very briefly, I don't want to get too much of a deep dive into this, but what I alluded to is the inactivity, deconditioning, and medical conditions all contribute to fall risk. As you know, with increasing levels of memory loss and loss of executive function, poor judgment, that can be a precipitating factor for falls. We know all the medications that are associated with falls: sleepers, anticholinergics, opioids, and anxiolytics are the big offenders. Believe it or not, bifocals predispose you to fall risk. I had a guy complain yesterday about his near fall because he said he was looking down with his trifocals and couldn't get his bearings. And so one of our recommendations is that when people are walking and if they need eyeglasses, that they wear distance glasses and not bifocals or trifocals or progressives or whatever they are. Cerumen impaction, believe it or not, can contribute to falls because there's an imbalance, and sometimes people use their hearing as cues for balance. I can't tell you what % of falls are related to hearing impairment, but it is associated with that. And then environmental changes, clutter, wet floor. My geriatric nurse a while back in the hospital slipped on a puddle of water from a spilt water container, wound up breaking her hip, and she was a young postmenopausal, individual. So, even for the most robust healthcare workers as well as patients, slippery floors can be an issue. And then also refusal to wear or to use assistive devices is another reason for falls. Next slide, please. So, I forget this guy's name. Oh dear. This is the gentleman that raised $1 gazillion for the British healthcare system. He was a 90-something-year-old World War II veteran. And he admitted that he always didn't like to use his assisted living or assistive devices, but you can see he's got his cane at the ready. So when he stops using his 4-point rolling walker. I just wanted to mention that some of the other reasons for falls and why we track the time of day and the location is that there is an incidence of what we call postprandial falls. So 30 to 60 minutes after eating a reasonably large meal, there's a group of patients that become hypotensive. And so doing orthostatic blood pressure checks on somebody that may be wobbly or have a history of falls might be an evaluation or a root cause analysis that you might want to do. Next slide, please. So the project goals for our PIP on falls is really twofold. We want to focus on one, prevention, and to understand how people are doing their fall risk assessments, and then what you're doing to mitigate that risk. So that's going to be one level of discussion. And then the other one is the actual intervention for a fall. What do you do for a post-fall assessment? How soon do you do it? And how do you develop a patient-centered plan as a consequence of that? Next slide, please. So we have a poll, and we want to address some of these questions here. So why don't you go ahead and launch that? So we'll just give a few minutes for folks to do the poll here. The first question is, how often do you conduct fall risk assessments? So that's, facility-wide. And then the second question is, what tools do you use to assess fall risk in your facility? So there's the AHRQ tool. Some people use the Morse Falls Risk Assessment, the Hendrick 2 fall risk model. I think they use that a lot in hospitals. And then if you're not sure if you use a variety of tools, that would be fine. So as we get those two questions, we'll use those as a point of conversation. Yeah, so thanks, Cindy. Cindy reports that we do a fall assessment after each fall. So that's good. Those are important elements, and we can talk a little bit about how you go about doing the fall. Yeah, so everybody does a fall risk on admission quarterly and significant changes after all falls. That's good. Yeah, so technically, if there's a change in medication, that should also prompt a fall risk assessment, particularly if somebody's prescribing one of those fall risk medications like a sedative, hypnotic, antidepressant. Even though you're treating the depression, for example, or anxiety. So yeah, thanks. We do what April does. All right, that's that. I like that phrase. We do what April does. It's like, what was that cereal? The Cheerios or whatever. Or Wheaties. Mikey likes it. That's great. Do we have the results from the poll yet? All right, so the first question looks like folks are pretty devoted to a quarterly assessment. That's good. And again, I would like to emphasize that we all think about when there's a change in medication or a change in status as a policy change that you might want to think about going forward. But congratulations at least on the quarterly assessment. And certainly everybody that comes in, a new admission, whether they come from the hospital. So the biggest fall risk, by the way, is in transition. So if you're going from the hospital back to the facility or as a new admission, those are the highest risk zones the first week with which they enter the facility from either home, transfer from another facility, or from the hospital. Those are the highest periods for fall risk. And then for the second question here, what tools do you assess fall risk in your facility? So it looks like we've got a little bit of homework to do here and figure out what might be the best tool to use. Now, it may vary from facility to facility. And I'll just point out that, for example, in my clinic, we're trying to use gait speed as a fall risk measure. Some other people use timed up and go. Some people will use a checklist, so certainly fall history, medication history, and so forth. So there are all those different tools. Okay, great. Thanks for that feedback, and that gives us a good view of the spread of our understanding of fall risk assessment. Can we move into the next slide, please? So what interventions do you use to manage fall risks? So some people have put in some comments there. If you want to add what you do to manage fall risk, how many people, for example, use a standard vitamin D supplementation as a standing order for a fall risk mitigation?
I would also be curious too, guys, if you have a grocery or a checklist of different items that you could check off that you, depending on what the situation is, or if you're really trying to individualize that intervention. I mean, sometimes you can use those those checklists. I'm not saying that they're a bad thing to get started, but just to make sure that you're individualizing it.
Yeah. So the big question really is that what are the potential gaps in the person's care plan that could lead to a future fall? So So again, we want to distinguish between those that are at risk for falls versus those who have actually fallen, right? Because we know once somebody's fallen, they're a risk. And I dare say that probably everybody in long-term care is a fall risk. So it's kind of like almost a moot point for doing the assessments. But there are different levels of like I say, fall risk. And I think the Moore scale, provides a gradation. There's also the Berg scale is another scale that's used. It's a 53-point scale. And so if you score really low on the Berg scale, you're considered a very high risk. If you score in between, you're a moderate scale risk. And then if you score like 40 points, you're considered a lower fall risk, but still a fall risk. Oh, good, Allison, thank you. So for someone who scores a high risk for falls, we place a red tag on their walker or assistive device to indicate that they're a fall risk. Yeah. So the question is now, did you ever use that as a plan, do, study, act cycle? Allison, have you actually figured out whether those red taggers are fall less as a consequence of that versus people who are not tagged?
No, that's not something I've gone back and tracked data on, but something I should do.
No, good. Yeah, thanks for sharing that. That's perfect. Because we've got this, so identification is part of it. And so once you put this red tag on, there's a couple of things to consider. One is that when you first start the red tag service, it's kind of like concierge or whatever, the valet service is what I was looking for, right? Here's my red tag. Does it really change the behavior of either the resident or the staff, right? So are eyes on that individual more or less? And really, does the eyes on make any difference? I've always commented that, supervision and having people like even right next to the patient, knowing to have a high fall risk, very, very infrequently prevents falls. I mean, honest to gosh, we upgraded our staff, in the dining room, all hands on deck, and we never put a dent into the fall rate, because by the time somebody got up or, was moving, they already hit the ground. So that's why, things like the red tag identification thing might be good, and it might be helpful in the beginning, but then the question becomes, is there a fatigue of staff, that say, well, that it's, red tag in and, out one ear and, in one ear and out the other. Falling star program where they had stars on doors and assistive devices. Yeah, so I think really, again, the identification of fall risk. So this presumes that you've already identified these people as high fall risk. So now the question is, what do those tags do in terms of different behaviors? Does that mean that the CNAs have them stand up and sit down 5 times every time they go into the room, to do some level of exercise? What's different about that red tag or star tag in terms of staff encounters or physical activity programs, core balance training programs? Are these the people that you, with assistance, have them stand on one leg while they're doing their oral hygiene? Things, any type of the things that, improve balance. Yeah, thank you, April, for your feedback. So fall education for staff is ongoing. That's always important. Not sure how much staff pay attention to learning. Well, thank you for that comment. You guys are like amazingly insightful. Like, you're bringing up all these points. And so these are things that we need to take back to the think tank here and come up with ideas. So how do you know if, after the training program, people not only know better, but they're actually applying that? So this is the exact same question that comes up with medical education with our medical students. I'll teach them the geriatric 4Ms, and then I go back to their medical notes and see that none of those geriatric 4Ms have ever been written down, even though they know about it. And you ask them, well, so what do you know about the geriatric 4Ms? And they say, oh yeah, we talk about mobility, we talk about medication, what matters, and mentation. And I said, well, why isn't it in your note? He says, well, I forgot to do it or whatever. So again, it's, developing these habits and connecting behavior with the learning. So thank you for pointing out that potential gap. We don't know, but again, these are things that we need to contemplate as you develop your PIPs on falls. And so I think certainly Allison's red tag, she's got her PIP maybe for the month. If it has, of course, Allison's probably got 10 PIPs going on, so I don't know about that. So you have, Jennifer, are you able to talk to us a little bit about the post-fall huddle tool? Who developed that, and how does that work? Yeah, thank you. So everyone working on the fall gets together and answers some questions regarding the fall, comes up with new interventions, et cetera. Yeah, that's fantastic. So, and hopefully it's interdisciplinary, so that, it would potentially include the PharmD, maybe by phone, and also certainly the physical therapy. And honest to gosh, you might also include, dietary and others in that too.
Yeah, that's what I was going to mention. Anybody who works on that hall or that unit during that time frame, say it's a 2 to 10 shift, and you've got, your housekeeper, your med aide, CNA, nurse, whatever, because they're right there visibly seeing what that routine of that resident was, and may be able to provide you more insight than what the CNA alone would. So if there's the opportunity to pull them in to have that quick fall huddle, you could really probably get some good insight.
Yeah. Well, I see that we're at the hour and we want to be respectful of your time, but this is really, and as predicted, this particular session, we have a bunch of slides that we did not cover yet. So thank you for zipping through those. Oh, the $50 bonus thing. Yeah, get your homework in. So for phase 2, the newbies on phase 2, just remember that as we have homework each week, we reimburse you $50. Sorry, it's not all that a lot of money, but gas money, I guess. For those that own Ford 150s, pickup trucks. So we do give a stipend, and the homework for coming up is that we want to begin the RCA, the root cause analysis of falls in your facilities. And again, if you already have a tool for that, go ahead and use it. I always express I like the fishbone, but some people like the 5Ws tool. And then we want you to see about using the fall tracking tool. So we get that from Michelle Lochner, and we can send that out again. I think we've sent it out once already. And then the post-fall huddle tool. And then also what we're going to do, so that's the homework. So the main homework is using the root cause analysis, format. And then if you can submit that by between now and next week, that would be useful. With the understanding that we'd like to share these root cause analyses going forward. And Kelly was just saying, please think about your fall process interventions prior to next week. And then we'd love you to share your practices, which we've started already. So I like the fall huddle, checkbox on the back of the Vital machine. That's pretty good. And I think we'll get some good ideas from folks around. So this is what we want to do. We want to get your ideas. What are you doing currently? And much like Allison said with the red tag service, how can we make it even better? So we will collect all these ideas and comments. I like the Room of Doom. It sounds like a Disney thing that Allison mentioned about the conference there. So we're going to look forward to learning a little bit more about that. Okay, so homework next week, root cause analysis for falls in your facility. We'll share those and have a discussion about that next week. And we hope that you have implemented or are following up on the data for your PIP on social isolation. So you should be using the post-intervention UCLA loneliness scale on a small set of patients that were involved in the intervention and see if you've moved the needle towards lowering the loneliness symptomatology. All right, any comments from Jean, Michelle, Kelly, Vanessa? Any closing comments?
Just thanks for all the sharing today. That's awesome.
Yeah, you guys have reached a new level. We'll give you a $50 bonus just for being so participatory.
Ditto.
I'm feeling really generous here. That's great. Fantastic. Okay, so we'll all catch up with you next week. Have a good week.